So what, as a think tank, we want to hear your views as frontline service users, as frontline workers, as policymakers, to find the best policies so that we can conserve our NHS for future generations. So that is one of our aims for the British Health Alliance. Also, I'd like to take the opportunity. I'm not sure whether Emma Hogan has joined, but nonetheless, I'm going to say it, and she'll probably blush. Emma Hogan is our BHA secretary, and recently she's been selected as a council candidate in a by-election in Brighton. She's a frontline psychiatrist, and I think it would be great that she will be, if we hope that she will get elected, that she will be able to shape local government policy with her first-hand experience of dealing with patients and service users in the pandemic and post-pandemic. So, and finally, before I finish speaking, this is a month when we've been celebrating International Women's Day. Yesterday, we also marked the first day of the pandemic lockdown. I'd like to remember all of the people, the well over 126,000 people who have lost their lives to this pandemic, and the 2.7 million people across the world. Also, I'd like to remember my colleagues, women and men in the NHS, in the front line and across the public services who have lost their lives to the pandemic. We remember you, we salute your sacrifice, and we will continue working to improve our NHS to make a better life and better health for our nation. So without much further ado, may I ask the Right Honourable Jeremy Hunt MP to speak.
Thank you, Anwara, and thank you for inviting me. And I think with these Zoom seminars, it's best just to keep them as interactive as possible. So I'd love to hear your questions, but let me sort of stir things up with a few thoughts. First of all, my great passion through my time as health secretary, and in fact the reason why I wanted to continue in this area despite not being a doctor or having a clinical background, but as chair of the Health and Social Care Select Committee, is patient safety. And I've always been very concerned that in modern healthcare systems around the world, we should be doing more to deal with preventable harm and death. And I think the pandemic has actually brought that to the surface in a way that perhaps people hadn't appreciated, because the latest figures we have are that around 30% of COVID deaths in UK hospitals were from people who actually picked up their infection inside a hospital. So between 8 and 36,000 deaths. And you mentioned the tragedy of nearly 1,000 frontline health and care professionals who died during the pandemic. The rather sad truth is that these were on the whole not the professionals working in ICU units who were covered in head to toe with PPE. They were doctors, nurses, healthcare workers working in other parts of the hospital, in the dementia wards, the geriatric wards, the pediatric wards, because we didn't take sufficient account of the fact that around a third of the people with COVID are transmitting it completely asymptomatically. And that has been the thing that has caused us the biggest problems. So I think the patient safety agenda is one that is going to become increasingly important as we work out the lessons to learn post-COVID. But the real point I wanted to make is that I thought very hard about what the NHS stands for and its history during the 6 years I was health secretary. And it was set up in 1948. It was a Labour government, but they did it with cross-party support. And in fact, it was a Conservative government in 1944 or a Conservative health minister who put forward a white paper which first floated the idea of a national health service. And it has become part of our British identity because we were one of the very first countries in the world to set up a universal healthcare system. And this is something I think we're rightly very proud of, and it plays to our British values, that it doesn't matter who you are, rich or poor, young or old, city or country, north or south, you should be able to access good quality healthcare without having to worry about the state of your bank balance. But the other thing that was interesting about 1948 is that we were completely broke as a country. It was at the end of the Second World War. There was really no money. And this was really a pretty expensive endeavor. And yet the government at the time had the imagination and vision to press on with setting up the National Health Service. And so the question I'm asking myself is, we've just come through the worst, the biggest and the worst and the most difficult challenge the NHS has had in its entire history in the last year with this pandemic. And we're not over it yet. But are we going to show the same vision and imagination that our forebears showed in the late 1940s to set the NHS up for the 21st century? And I hope we do rise to that challenge. And I would say that if we're going to do that, there are really three big things that we have to sort out. The first is we have to sort out the issue of recruitment and training of NHS staff. We never seem to recruit enough doctors and nurses. When I was health secretary, I increased the number of doctor training places by a quarter, set up 6 new medical schools. I was very proud to do that, but I always felt the way we plan for the future in the NHS is very back of the envelope. And I think we need to have a system where we have proper long-term planning, where we say we're going to need this many doctors, psychiatrists, nurses, people in every single specialty. In 10 years' time, 15 years' time, that means we need to start training this many doctors now, because it takes 7 years, as everyone knows, to train a doctor, and so on. And I think we need to have much more science in our workforce planning. And I think that would really reassure people on the front line. They know we don't have enough clinicians at the moment, but if they thought at least we had a proper plan in place to deal with that issue over time, I think that would be something that would be really welcomed by NHS staff. Secondly, we need to sort out our social care system. And I was thrilled this afternoon. I was questioning Boris Johnson at something called the Liaison Committee, where MPs question the Prime Minister 2-3 times a year. And I said to him, you know, we have a 10-year plan for the NHS. Don't we need a 10-year plan for the social care system? And he said, for the first time, yes. And so the government's committed to a 10-year plan for the social care system. He's even hinted they might mention the social care system in the Queen's speech, but that I think is a major thing and a very positive step forward. We now got to deliver this, but there's no point trying to fix the problems of the NHS, ignoring the challenges in the social care system, because both systems are grappling with this extraordinary fact of an aging population. And that didn't stop for the pandemic. Last year was the first year in human history where across the world there were more over 65s than under 5s. And if we're going to deal with that problem, we've got to think about prevention, about keeping people healthy as they grow older so they don't rush into an A&E department at 9 o'clock on a Friday night. That means investing in keeping people independent and helping them live safely at home for longer. And that is about social care reform as much as NHS reform. And the third thing is, I feel that if I think about Nye Bevan, whose politics I don't really share, but, I was proud to be a health secretary after him. And I think his passion and commitment was what got the NHS off the ground. He set up what I think is probably one of the most accessible and fairest healthcare systems in the world. And survey after survey, the NHS comes top in terms of its ability to minimize the difference in the quality of healthcare received by the richest and the poorest. The NHS does better than France, Germany, Switzerland, certainly America, but many other countries in terms of the equity of its provision. But if we're honest, when it comes to the quality of healthcare, we are still middle of the pack. We still have cancer survival rates that are behind those of France and Germany. We still have too much avoidable harm and death. And there's still a lot we could do. And I think that vision of the NHS wasn't just about us being the fairest healthcare system in the world. It was also about us being the best healthcare system in the world, offering the highest quality, safest care. And so I think we need to have a renewed push to really transform the quality of our healthcare and make sure that we can say that whether it's cancer or heart care or pediatrics or strokes or general practice, this country is one where we offer the very best in the world. And I think very often we do, but I think we also, if we hold the mirror up in front of ourselves, we know we could do a lot better. And that needs to be part of our vision for the NHS for the 21st century. So does that give you a few things to kick off a discussion on? I'll leave it there, but let's open it up for a bit of Q&A and discussion.
Okay, so we can take a few questions and then we'll move on to Professor Shafi Ahmed. I think that's a good way to get things heated up. So can we see who's any hands raised?
Can I ask?
Yeah, so Shaukat, Dr. Shaukat Ahmed is a GP. Yeah, go ahead.
Thank you, Dr. Ali, and Honorable MP and our ex-Health Minister, Mr. Jeremy Hunt. I've got a few questions. I'm a GP now, but I've been working in the NHS for 25 years, and I'm an overseas foreign graduate. I came from Bangladesh, when I was a kid, and now working 25 years. Now, I've worked in the secondary care, in the hospital, primary care, so I've got quite a bit experience. Now, my question to you is, if I just take a background, you've described the NHS, I still feel very passionate, and that was the reason that I came to the UK. That was my driving force, Otherwise, that time I had the opportunity to go to other states, but NHS was, it was a crown in the jewel, and that was my driving force to come here, work here, to get trained and to serve the people and the country, which I'm doing. Now, the problem is NHS has gone through various phases of the last 25 years since I've been working, Initially, the Labour, then the Tory, obviously, everybody has got their own agenda, and there have been so many changes. Now, my main concern to you, obviously you're a very experienced MP and you've been all through this, is following the Brexit. During the Brexit, there was a big push, and many questions was asked, what will keep off hands of our NHS, which I still think that should be. But now, because of the rules and regulations that's been relaxed from the EU, now we're seeing that, I'm just fearing whether NHS going to be existing in about 10, 20 years, because obviously now what's the trend is happening, the USA, because it's a very lucrative and very profitable thing, they're coming in, they're going to take over various, and from my personal experience in the surgery I worked, 12 years ago in a surgery I worked, and then that was taken by a private company, which gradually built up, and at the end, the quality of the surgery was so poor, I left the surgery in disrespect. So I was.
Thank you, Dr. Ahmed. I think we'll take the questions in maybe fours, and then Jeremy can answer.
Okay.
Because we've got, if Mayank goes next, and then Ami Sharma, Santosh Patel, and then Sade. And then Jeremy can answer, give a reply, yeah?
Hi, Jeremy. Hi, Jeremy. I'm Mayank. Mike may be easier. I'm a community pharmacist, and I represent pharmacy in London quite a bit. Where do you see pharmacy in this post-pandemic era? So I know pharmacy has really stepped up. Like even in my organization, we're running. Sorry, can you hear me? Yeah. Okay. Yeah. So yeah, we're running a COVID vaccination site, but I look at the allied healthcare professionals, and my biggest worry, and you're right about, we need to look at the future, is how do we look at building social and healthcare together? Because at the moment, the mental health of people is really suffering, especially the youth. And I think is how do we ensure that we reach every sector and every member of the community? And I think, don't get me wrong, I think community pharmacy is well placed, but previous regimes and the current regimes don't really see pharmacy as a way forward in every single aspect. And it's just, how do we bring it forward? So some of the things you're saying about blood pressure monitoring and all of that kind of stuff, we need to look outside the doors of the GP sometimes.
Thank you, Mayank. So Ami, so can I just ask everyone to be brief with your questions, because we have two more speakers. So yeah, please. So Ami, your question.
Sure, thank you. Thank you. Honorable Minister, I have a suggestion. I'm a proud NHS first responder, and I love helping people. I've my longest call has been 1 hour so far. And it's great to just hear people happiness when you speak to them. I haven't got any advice, I'm just talking to them. So my suggestion is there a role in the 10-year social care plan for the NHS first responders, or a reincarnation of that to help with the health and well-being of our elders?
Thank you, Ami. So we'll take Santoshi's question, and then there's two more questions, but I think we'll let Jeremy come back on those, yeah? So Santosh Patel.
Yeah, thank you, Dr. Anurali. Hi, Jeremy. So I think my question is around with the new trends that is coming up. So we see that there is a medical tourism which is picking up in the world. So, and that's I think going predominantly towards lower economic countries, but they can provide a better medical health care than Europe. This in turn tries to push NHS towards privatization, or maybe providing some kind of laws or policies that can help private organizations to come up. So what is the plan that government has got so that the private tourism can come back to UK rather than going out, the medical tourism? Thank you.
Okay, well, thank you very much indeed for some very good questions. So let's go through. I mean, first of all, I think you should not have any doubt whatsoever about the NHS being at risk from a Conservative government or a Labour government, to take Dr. Ahmed's question. This is not a party political gathering, but you know, it's something the Labour Party tries to throw at the Conservatives at every single election. The NHS is not safe in your hands, but we still carry on winning elections. If people didn't think the NHS was safe, they would never allow us to win elections. They would vote against us because it's so close to everyone's hearts. But when I was Health Secretary, I secured a 20 billion increase in the annual budget of the NHS. That's about 1% of our GDP. That was under Theresa May. That would not happen if there was a government that was planning to privatise the NHS. And indeed, under Boris Johnson, even more money is being committed to the NHS. So please put your mind at rest. And in all the discussions about trade deals with the US, the UK made it absolutely clear to Donald Trump that the NHS was not on the table. We weren't, and he accepted that. The role of pharmacy, Mayank's question. Well, I think what we've got to do is recognize if our main challenge in modern healthcare systems is older people, then really this is about joining up the care that people with complex needs have. Not just one thing wrong with them, but 2, 3, 4 things wrong. And what we want, I'll give you a practical example. You know, we want pharmacies now are getting some access to people's GP medical records. They can access the summary care record. But I think the next step is for them to have read-write access to the entire medical record, so that someone can go to a pharmacist, have a conversation with their pharmacist, and the next time they go to the GP can see a record of that. And so really it's about that integration. And I think GPs were previously very resistant to this. I think they've realized now that anything that reduces the extraordinary increase in demand for appointments that they've been having to deal with over the last few years is a positive. And so I think they are absolutely up for that. For the same reason, Ami, I think there's a great opportunity for NHS first responders. Thank you for what you're doing. I think that the ambulance services, GPs really welcomed the tremendous contribution made by NHS first responders, and I think the NHS is absolutely supporting that. And then Santosh's question about medical tourism. Well, I think there's a big commercial opportunity for the UK, and I don't have any problem with, you know, the private wings of NHS hospitals treating people, because I think that helps them to expand their facilities and fund their NHS work. But obviously, their NHS work must always remain their priority. I know the Cleveland Clinic, I think, is building a new hospital in London. But I do think, and this is something that has that not all doctors agree with me on, but I do think the NHS is right to have got better in recent years in making sure that people aren't flying to the UK for free NHS care when they haven't been contributing to the cost of that care through their taxes. I think we had quite a leaky ship, and I think in some ways we still do, but I think we have started to get a lot better at this. We just don't have the capacity for the NHS to become a national health service for the whole world. And although it's very well-meaning sometimes that we should want to help people from poorer countries, the reality is the people who fly to the UK are not the poorest people in Africa and India. They are actually middle-class Africans and Indians. And therefore, we need to make sure that they are paying properly for their care. I have no problem with them coming if they pay for it. So that's a different type of medical tourism. Next questions then, Anwara.
Jeremy, should we let Shafi speak and then take a few more questions, so then the whole panel can answer some of these questions, because there's a question from Nadey Hakim, there's Sade, and there's Zera in the pipeline. So let me introduce our next speaker. He doesn't need actually an introduction. He's the most watched surgeon in the history of mankind. He's a colorectal surgeon, he's a teacher, he's a futurist, an innovator and entrepreneur. He's won multiple awards, which include the Jeff Prize, the Digital Leader, the Future NHS Prize in 2018. He was recently nominated for the Nobel Prize. And Shafi conducted in 2014, he used a pair of Google glasses and performed live surgery and streamed it to 14,000 students across 132 countries and 1,100 cities. So we have a futuristic surgeon, and I'd like him to kind of talk to us about, the NHS has gone through a wholesale change with the pandemic in the way that we work and the way that we've embraced technology. What further can we do to meet the challenges post-pandemic? So Professor Shafi Ahmed, floor is yours.
Thank you so much, Anwara, for the kind invitation. Also to the exec team at the BHA. It's a privilege to follow Jeremy Hunt, of course, and give this talk. And Jeremy did a great job in talking about the NHS, its past, its history, where we are at the moment. I want to thank him personally for his chairmanship of the Health Select Committee and holding people to account. You did a great job, Jeremy. Please continue with that. We follow you with interest. I'm going to take you on a journey. I want you just to relax. This is Wednesday evening at 7 o'clock in the evening. I want to put your pens down, relax. I'm going to take you on a journey about the future, what the possibilities are. I go around the world talking about the future of healthcare, what can be possibly achieved with all the technologies that are around with us at the moment. So I'm just going to share my screen, and hopefully the technology won't fail us at the beginning. And I'll take you on this little story about the future. So I'm sure you can see this. Can you see this? I'm just going to go to share my screen. Okay, so I hope you can see this. So my role in this next 20 minutes is talk to you and impress upon you the roles of technology and AI and how it's going to affect all of our lives in the future. So let's think about what that means. First of all, I'm going to play a little video as a glimpse of that future of healthcare, which I created with Anthem, the largest insurance provider in the US, around what they were thinking about the future of healthcare in the US market. Okay, so that quote that you just saw there is from Abraham Lincoln. The best way to predict the future is to create it. That's really kind of what I want to see, how we go forward. Think about how do we create this healthcare future together. So here we are. This is an example of where we are. In 2020 and 21, we are living in exciting times. I think it's the most exciting time to be alive in medicine. We've never seen the riches of technology come together at the same point of human existence. It's an inflection point for humanity. What am I talking about? It's not just AI on its own. It's immersive technology, AR and VR. It's using nanobiotechnology. It's mobile 5G networks using increased connectivity, genomics. We've seen all these coming in, including robotics, etc. So AI is a part of this wonderful journey we're in, and it's called the convergence. And that's why it's so exciting as we go forward to reimagine what healthcare will like in the future. First of all, we've got to create the healthcare workers. And Jeremy mentioned, he's increased the capacity into 6 other medical schools during his tenure as health secretary. And also, we have a huge shortage of doctor nurses going forward around the world. The WHO have said we're going to be 30 million health workers short by 2030. That's a huge hole globally about how we feel that. Now we've got to create the healthcare force of tomorrow that's relevant, that's digitally enabled, that understands language. So now the NHS has created these academies, we have the entrepreneurship program, and we have the accelerators to help support innovation at the heart of the NHS. And I actually was Associate Dean of the Medical School for 10 years. I've created a course called BARTS X, which is bringing digital health, innovation, entrepreneurship at an undergraduate level. And I'm doing the same in Imperial, saying that we've got to train people in a different way to have the knowledge base to create the future healthcare workers of tomorrow. And in fact, I work with Abu Dhabi as an advisor to the government, and they take it further. They've created a university purely for AI, which opened up in January of this year. They want to create the new cadre of people from engineering, from computer science and healthcare workers to imagine the new challenges of tomorrow. So people accelerating this whole interest in AI and technology. Talk about AI and deep machine learning. There are areas that I think really interesting that we're working upon around the world. There's diagnostics, which is obviously the key to all of this. There's drug discovery, there's the chatbots, and of course, there's things like the AI surgery, my own profession, going to be revolutionized by the use of AI and deep machine learning. If you look at the kind of where we are, as last year, hundreds of millions of dollars were invested into AI platforms and programs. This is just an example of where we are. On the left-hand side, you see the kind of AI inputs with natural language inputs, patient data biometrics, or even data from providers, the operational data that's necessary to make seamless healthcare work. On the top, you'll see where these examples might be used. For example, early detection, triage, diagnosis, treatment management, and looking at outcomes, measuring outcomes with improvement. And there's a whole plethora of companies out there now working in these spaces, trying to figure out this new landscape of healthcare. And it's just done really well. We, about a year and a half ago, or 2 years ago, NHSX came out. Then, of course, we've been pledged over £250 million to create the NHS AI Lab to improve diagnostics and how AI is used in clinical practice. We've seen now a kind of a document produced a year ago around what does that mean in the NHS, how do you adopt it, how you translate it, and of course the buyer's guide looking at what companies are working in that partnership in AI. What are the advantages about? Well, here we are. These are a couple of examples where AI is shown to be of benefit. And it's very good for images, scans. And we're seeing the DeepMind team in London working with the Moorfields Hospital to look at OCT scan to predict retinal disease. We've seen scans from x-rays, images being now used routinely to be diagnosed with AI. And the chest X-net group were the original ones from Stanford who showed that we could be better with AI at diagnosing chest x-rays than a single radiologist. So we're seeing now how we're utilizing this AI platform. And the NHS, of course, isn't immune. Here we are over the last year, a company in the UK who are called Kiro AI. What they did, of course, they used the images from patients with COVID, CT scans, to help diagnose and perhaps predict the outcomes. And what the NHS did, amazingly, they allowed all these scans to be obtainable anonymously, so everyone could use it as a resource. Amazing repository the NHS did very quickly during the pandemic. My own specialty of colorectal surgery, as a cancer surgeon, we do colonoscopies, and here we are. This is an image looking at how you can diagnose polyps on a scan, for example. You can't see it, but soon you'll be able to see it as it comes closer and closer. The AI has picked up a polyp that could have been brought out before. Can you imagine that with a new capsule endoscopy now that's coming out, a screening method that's been launched only a few weeks ago. And actually this might be the future. Hey, connect things. So it's the AI, it's the robotics, maybe 5G connectivity to do that. Mobile scans, we see ultrasound coming in, now being powered by AI interfaces, whether it's handheld portable devices, it democratizes the access to diagnostic. This can be done anywhere in the GP primary clinic, it can be remote areas around the world where AI will help diagnose problems immediately, take away some of the manpower issues. We've been amazed at how we've seen this vaccines develop within a year. The quickest vaccine on record to be developed was about 5-6 years. We've seen it happening about 9 or 10 months. And a lot of this going, as we go forward, will be this drug discovery pathway using AI. Millions of targets can be mapped using AI, and so the drug discovery pathway will be much faster. Benevolent AI working on clinical trials and rare diseases, and Celularity looking at really small molecules using AI interfaces to see which targets are going to be most beneficial to go for. We've seen the last year, of course, how we transitioned from the face-to-face contact to remote contact. This is a picture from 924, 100 years ago almost, looking at how the futurists of 924 were predicting that we're looking at patients through a screen, i.e. telemedicine, way before its time. They were thinking, actually, we need to be more remote. And of course, now we're seeing more remote medicine, telemedicine coming in, and now that empowered by AI. These are the chatbots, whether it's Babylon, Ada, or Sensely, all allowing you to put your information in. And I know the NHS 111 service will be powered by an AI chatbot to triage patients, to manage patients better in the community, avoiding unnecessary admissions to hospital. Now we're seeing these rolled out around the world. Again, access is going to be the key for all this. What about your voice? Your voice actually a biomarker. Did you know that? It's a powerful marker. Here, this is a company from Israel who looked at your vocal biomarkers by speaking to a smartphone 1 or 2 minutes a day. They could predict the onset of cardiac failure in patients with ischemic heart disease 2 weeks before it arrives. So therefore, they can prevent unnecessary admissions, for example, keep patients at home, avoiding complications. And of course, Amazon Alexa and others working on voice technology enabled systems so that you can now access healthcare in a different way. This is, of course, Babylon's image of the future. And I share that because I think it adds a lot of value.
Hi, Louise. My name's Dr. Kultag Archer. Nice to meet you.
And what you see here is a mixture of things. You see face recognition, AI looking at patient expressions. You see voice to text. You see diagnostics happening in AI. In real time, in the future, you could actually minimize a consultation, improve efficiency so that you're actually, as a doctor, much more efficient in your process and collect the valuable data that's necessary. Here we are. This is an example about looking at patients in the future more remotely. We're seeing diabetics, patients with COPD, asthma being managed more remotely in the community. Before they had regular appointments, that's all changed. So can we now remotely manage people better? Of course we can, whether you're using the glucose monitors, for example, like Libra system or Libra 2 that's come out, ECGs using remote ECG monitoring, suits that can measure your blood parameters or your measurements like blood pressure, pulse, etc. in real time for athletes and other people, and also artificial pancreases. Moving on to remote management of patients, that makes sense. Care needs to be moved from secondary care to primary care and social care, which Jeremy's alluded to already, which absolutely makes sense to use the same money smartly. We're seeing sensors come in, whether it's your smartwatch that we all have now, of course, measuring your blood levels on ECGs, nanobots in the stomach, skin sensors or measure your glucose constantly for a few months, or skin as interface. So all these kind of things now are coming in so that we can actually measure more and more data to keep patients at home and manage wellness rather than sickness. And that's the key. A couple of minutes just to look about my own field of surgery. We talk about what's called digital surgery as an interface. What we're seeing now is a whole conundrum, change in the way we perceive surgery. There'll be robots coming in. We've seen CMR, Cambridge Medical Robotics in the UK, with a new platform called Versi, has been launched a year ago, doing amazing things for British technology. We're seeing enhanced visualization, advanced instrumentation, connecting the system, so you have more data collecting, and advanced analytics. So hopefully in the future, surgery will be much more precise than it has been before. We can map it much more carefully. The operating theatre will change because you have all these kind of inputs coming in, which we're now optimize and use to benefit the patient. So these are going to be exciting things that are happening in around the operating theatre. My friends from Canada and also from the Netherlands will be working on the black box. A lot of information is in operating theatre we don't capture. Having cameras around, capture all the data, what's happening, can analyze team performance, how we're getting on, And crucially about patient safety, as Jeremy alluded to, patient safety on all these things will be improved because you have much more data to look at what went wrong, what it has gone wrong, to analyze and to make sure that we make changes. We've seen platforms like digital surgery. During the operation now, you can plan surgery. So as you're doing the operation in laparoscopic surgery, the computer will tell you where the structures are, avoiding unnecessary damage, improving outcome. So the planning during the operation and navigation tools will be improved as we go forward. And this has never been happened before, of course. Last slide will show you my vision of the future. We did this about 2 years ago when I was talking about remote work. A lot of my stuff is about virtual work and being remote. We did this a couple of years ago, bringing people together, and they are together, and I think you enjoy this.
Hi, everybody. Hi, Shafi. So the HoloLens itself really allows us to reshape the way we connect people, we communicate with people, and also to be used in teaching and training. Initially, when you put the HoloLens on, it feels a bit strange, but actually within a few minutes, it becomes quite normal. It feels like you're just discussing cases with people in the same room, for example, like we do in normal hospital practice.
We can come in and actually look at this content in full 3D. And obviously when you're working in this case, the medical field, having a full 3D understanding of a situation, for example, is really much more powerful in solidifying how you want to navigate it in your mind.
So that was the glimpse of the future. And actually, there's a great quote that I'll leave you with by William Gibson, who's an American-Canadian author who coined the term cyberspace. What he talks about is that the future is already here. It's just not even distributed yet. And it's for all of us then in that case to start thinking about how we use some of these examples to facilitate healthcare for the future. Thank you so much.
Thank you, Shafi Ahmed, for that wonderful tour through our future, our current and our present and future. So there were questions from Sade, Zara, and then Nadey, but Nadey's going to be your third speaker as well. So if Jeremy has time, if you can take it, otherwise Shafi and the rest of the panel can answer. So if you keep your questions quite brief, then Jeremy can answer briefly as well. Sade, Zara, Nadey.
Good evening, Minister. My name is Shadi Ado, and I'm a nurse, also a counselor. And in my role, I've been in acute setting, I've been a district nurse, and currently I'm looking at funding. And the question from me to you, considering the role you've had in the past, is it not time for us to bring social care and healthcare together, particularly when it comes to funding, so that we don't have this divide between both? And also in so doing, maybe, I might lose my job, you might end up streamlining top management. But that's my question to you. Thank you.
Thank you, Sade. Zara, your question?
Just mute myself. Thank you so much for the amazing contribution from the speakers so far. So I work in the field of innovation, particularly international development, but I have helped run a health social venture accelerator. And my question really is, how do we turbo boost innovation in the health sector? What more can the government do? For example, how can healthcare innovators work better with, if you like, entrepreneurs, innovators, and also particularly development space? So to give you an example in development space, so Shafi, I found what you said really inspirational. AI in refugee work is going to be crucial because of the mental health challenges. You will know this. 1 in 5 Syrians have mental health issues, and practitioners have found that AI technology has really helped sort that. But I mean, imagine what that means if we had joined up thinking and connected healthcare professionals in a cross-departmental unit with the development sector and foreign sector. I mean, Jeremy, you're a former foreign secretary. You know this. You've seen healthcare is one of the massive development factors, and donor money the world over is contracting. So we need to do things more efficiently, but it's not enough just to, you know, cut down on HR and be more transparent. We need innovation. So I think to Shafi and Jeremy, that's really how do we do it? And I mean, my area has been innovation in the development space. Thank you.
Okay, I'm acutely aware that Jeremy's got to leave soon. So Nadey, do you want to ask your question, and then Jeremy could, in threes, he can take that question.
Actually, I'll take
any
it,
questions anybody else has, we can always send them written to Jeremy's office.
Jeremy,
Nadey.
always good to see you. You touched on the 6 new medical schools you have started or attempted to create. I don't know whether it has happened or not, but I want to ask you about the new private medical schools which are starting to appear in the UK. What are your thoughts about this potential plan? Because I know of at least 2 or 3 new private medical schools coming up. What do you think the government will think about that?
Okay, Jeremy.
Well, do you want me to come in? But I think you should also bring in Shafi for the second question in particular, because he would have more of an insight than me. Well, Shadi's question, I totally agree with you. We have got to join up health and social care. No question about it. You know, what does that mean practically? I don't think we want a big structural reorganization where all social care organizations become part of the NHS, because I think that will we'll spend hours rearranging the deck chairs. And what we really want is things that patients notice: a single care plan, a single budget, a single medical record shared between the health and social care systems that everyone can access, so that everyone they see, whether it's the people looking after them in a nursing home or their GP surgery or at a hospital, sees the same information about them, understands their care plan. And I think that would make the brilliant work that people like you do much, much easier. On innovation, Zara's question, I think Shafi's the man to answer this one, but I will just say one thing. I think government does have a role in boosting innovation. And when I was health secretary, I was very proud to set up the 100,000 Genomes Project, which was designed to make sure the UK became the first country in the world to sequence 100,000 genomes. That has stood us in fantastic stead in the pandemic. We're decoding half the COVID genomes in the whole world as a result of the development of our genomic capacity. And what's the next thing we could do? Could we say that by 2030, the NHS is going to become the first healthcare system in the world to decode the genome of every baby born in the UK, and the information about that genome will sit on people's electronic health records, so that doctors will be able to interpret genomic information at the same time as they make their regular diagnoses? I think that could have a very catalytic effect. And Nadey's question, I believe in a mixed economy. I think if we want the NHS to be the safest, highest quality healthcare system in the world, we have to be open to innovation. We should welcome it if people like the Cleveland want to set up hospitals in London, and because they are fantastic organizations and we can learn from them. And we will only succeed if we're open to the best in the world. And that means, you know, some of the work that Apollo does in India, some of the work that Kaiser does in the United States, some of the work that happens in the maternity sector in Sweden, where they have half our neonatal death rates. Openness is a great British strength. And so I think if there are more medical schools that are starting up, you know, it can only be a positive thing.
Thank you, Jeremy. So Shafi, would you like to take the question on innovation from Zara?
Of course. Look, I think we're in a better place than we were before with innovation in healthcare. There's no question about that. If you asked me a year ago, before the pandemic, it was a struggle, there were barriers. The pandemic has shown us how we can accelerate innovation very quickly. We've done amazing things in the UK about that. So the next thing is about how do you adopt and translate and keep it in the system. So at the moment we have got these organizations, whether it's the Academic Health Science Networks, NHSX, whether it's NHS Digital, the accelerators. So we're getting this kind of ecosystem, bring innovation to the heart of the organization. However, I think it's incumbent on every chief executive, every person in the hospital to bring innovation to the heart of every person's job plan. We need to encourage people, take part, improve their processes. It doesn't have to be technology. It's how to bring innovation to the heart of their job, whether it's a nursing process, whether it's a physiotherapist process. How do you ask them to redefine, reimagine what can be possible? And that's the question I put to every person in the UK. Thirdly, I absolutely agree with you in terms of the global perspective. Look at the WHO reports and the fact that we're going to be 30 million health workers short. We're now adopting digital technologies with the latest WHO report for the UN Sustainable Development Goals. How do we manage that on a global level? So I've been traveling a lot. In fact, the last 3 years, I've been to 30 countries, working with governments, colleges, universities to look at innovation, healthcare, and education. And I've been working in Gaza for 6 years on a program of innovation, how they can actually, in a country like Gaza, which is difficult to get to in a war conflict zone, how to improve mental health, how to improve surgical training, education, how to bring technology to those environments, because that's the real test. And you mentioned Syrian refugees. Of course, given the smartphone access, information, using smart technology will improve their own well-being and their outcome. So I absolutely agree, there's lots to learn about from the global experiences to improve and democratize healthcare. And that's why I think we need to be, innovation is the heart of that. The government has a role, we have a role, every institution needs to make that a priority. And I'm hoping, in fact, they'll be launching very soon something called NATHAC from the government, which is the National Academy of Technology in Health and Care. You heard it first here. Hopefully that will be launched in the next few weeks as a kind of organization that will embrace innovation in the NHS. That's going to be its role. Anyway, you hear that first, it will be announced fairly shortly, I'm sure.
Thank you, Shafi. Okay, so can I invite our third speaker, Professor Nadey Hakim, who also is the Deputy Chairman for British Health Alliance. He's a transplant surgeon at Imperial College. He's a bariatric surgeon. He's a musician, a writer, a sculptor. Again, another famous person. You know, he was one of the team, or the surgical team, to do the first hand transplant back in 1998, and the double arm transplant. He again needs no introduction. I think most of you know him. He's going to talk about the role of bariatric surgery. Now, you may have seen recently in the news, the bariatric obesity is the third highest risk factor of COVID death. This is something we've known in the NHS, and it's an avalanche waiting. I think it's a pandemic of its own volition. I personally feel that we don't have enough bariatric surgery to combat obesity as they do in America and other countries. And it's something that I think that we should be looking at. Professor Hakim will talk about bariatric surgery and its role in combating obesity. Over to you.
Thank you. Thank you so much, Anwara. And I don't want to keep everyone too long. I enjoyed both talks, and I'm afraid following Shafi's talk, I'm going to invite you to come back to planet Earth, because what I'm going to talk about is more what I've been dealing with over the last few months, especially with the pandemic. Anwara mentioned the fact that, bariatric surgery is of importance for obesity, which is a pandemic itself. What has happened is that we have not been able to operate much over the last 12 months or more. First of all, laparoscopic surgery has been almost stopped initially. It only restarted recently. Therefore, bypass sleeves could not be done. In addition, patients could not come to hospital. So what I'm going to talk to you about today, and I'm going to share my screen if I may. Can you see that screen now? Yeah.
Yes, we can see the screen, yes.
Perfect. Yeah, so I'm going to tell you what, because of the pandemic, we have been obliged to do, which is almost outpatient procedures. And this is one of them, which I want to introduce to you. You might have heard about it or not. I'd be interested to know what Jeremy thinks about it. It's called the ellipse. Now, instead of performing surgery in hospital, this ellipse is a very simple thing, which is involved just the insertion of a small capsule inside the mouth into the stomach by the surgeon, by the endoscopist, but without endoscopy. And when it's certain that it is in the stomach, because we take an X-ray, that capsule going to be inflated with 550 cc's of saline. And this is what happens when that balloon is swallowed. There's a valve, as you can see on the screen, which will keep it closed. And what happens 4 months later, that particular valve will be released, and the balloon will deflate and pass into the stool. So there is no need for endoscopy, no need for endoscopy to insert, no need for endoscopy to remove the balloon. And this is the degradable filament, which by itself at 4 months will just degrade and will open the balloon, deflated, and the balloon will pass into the stools without the need of an endoscopy. Now, the reason why it is tempting is that patients, I personally would hate to have an endoscopy. Therefore, a lot of patients would prefer not to have an endoscopy. And this is why it's quite an attractive procedure where the balloon is swallowed in the physician's office as long as there's an X-ray available, and then it's inflated, and 16 weeks later, the balloon will self-empty and pass into the stools without causing any complications. Now, the patients we offer the options for those patients who have failed, obviously, to have a medical weight management. They want to jumpstart their long-term weight loss. They just want a short-term weight loss solution and do not qualify to bariatric surgical options and or do not want surgery. In addition, some patients are so heavy with a BMI, let's say, of 60 or 70, they are not really fit for surgery. We can offer them the balloon first as a bridge until they lose enough weight to be safely operated on. And you can see from this slide that the ellipse is well positioned on the spectrum from the least to most invasive interventions. You can see the sleeve, the bypass, which are offered to patients with a BMI of 40 plus, and the balloon can be offered to anyone from BMI 27 up to 60, 65, because there is no need for any anesthetic. So the gastric balloon improves comorbidities. You look at the cholesterol, triglycerides, hypertension, metabolic syndrome, diabetes. All these are going to be improved because and thanks to the balloon. Now, the intragastric balloon function in part by increasing the gastric emptying time. Therefore, the food inside the stomach will stay there much longer. Therefore, you are going to be losing more weight that way. Now, what does the weight loss and weight regain look like during and after intragastric balloon therapy? A lot of patients ask, and people ask, what will happen when the balloon comes out? Now, it has been shown that up to 6 months after the balloon is removed or passed by itself, the weight loss of 80% or so will still be visible up to 3 months afterwards. Now, is endoscopy always necessary prior to the balloon insertion? Now, the old-fashioned balloon, not old, but we still do it, and I've done over 6,000 of the other balloon, which requires endoscopy. Now, you look inside the stomach first, make sure there is no pathology, and then insert it. But this is why you have to select your patients very carefully. Make sure that you ask the right questions prior to the insertion to make sure you are not missing something inside the stomach. Now, what are the potential complications of the intragastric balloon? Most patients will complain of pain, nausea, reflux. You can have gastric erosions, migration, small bowel obstruction, perforation, God forbid death. this is extremely, extremely rare. And the deaths which have happened really have been really secondary to other pathologies and not the balloon itself. So no serious adverse events have been shown. As I mentioned, nausea, vomiting, abdominal cramps. All but one event was rated as either mild or moderate, and I'm talking about all the experience with that particular ellipse in the literature by the company which is producing it. Now, what are the contraindications? Obviously, somebody who cannot swallow will find it difficult to have that balloon, and that's why you have to make sure you inquire about that before doing the procedure. Some conditions that predispose to bowel obstruction, previous surgery, like appendicitis, things like this, you should really avoid having that balloon inserted. Other contraindication, GI bleed, patients who are on anticoagulants should not have the balloon inserted. And other things like prior gastric surgery, even having had the lab band or bypass or sleeve, obviously you can't have this procedure offered. Now, the complications which can happen, the balloon can early deflate, leading to device passage, intolerance, dehydration, obstruction, dilatation, gastritis, GI bleed. All these things are rare but can happen, and you have to warn the patient about it. Pancreatitis is another thing which has been described, and this again, if you have a patient who develops pancreatitis, the balloon has to be removed as such, otherwise you can have problems. So what medication do you give the patient pre and post ellipse placement? Omeprazole, EMAND has really changed the life of many of our patients because EMAND is a fantastic antiemetic. We give it at day 1, day 2, day 3, and really it really avoids a lot of the sickness which has been experienced by many patients in the past. Buscopan for the cramping. In my own experience, between June 18 and May 19, I've done over 100 patients with ellipse, and the 1-year follow-up was obtained on 79% of the patients. The mean weight loss and the BMI before the procedure were 85 kilos and 31 respectively, and the total weight loss was 9, 11, and 8% at 3, 6, and 12 months. I have had, thank God, no complications with my series. So in conclusion, ladies and gentlemen, Mrs. Chairman, Jeremy Hunt, the ellipse is effective and a non-invasive method for weight loss, and it has really allowed us to help many of our patients during this pandemic. Thank you.